Hello, and a good day to everyone. My name is CB Mamril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome everyone to today's Research in Progress webinar on STD services, scope, and organization in California and Alabama, impacts for care and disparities. Before we begin, we'd like to acknowledge the funding and support of the Robert Wood Johnson Foundation, and I'd also like to remind everyone that during the presentation, you can type in your questions in the chat box that's located in the lower left-hand corner of your screen. So without any further ado, I'd like to introduce our presenters for today's webinar, beginning with Dr. Summer Starling, who is a health research scientist at the Public Health Institute in California. Summer's research focuses on adolescent health information-seeking behaviors in digital spaces and public health systems research for improving STD care and control. Summer coordinates the qualitative research activities and advisory board for the California Public Health Research Network and collaborates with researchers at the University of Alabama at Birmingham. Our other presenter is Dr. Robert Weech-Maldonado, who is a professor and L.R. Jordan Endowed Chair in Health Administration at the University of Alabama at Birmingham. Rob's research interest focuses on cultural competency tools for healthcare organizations, racial ethnic differences in patient experiences with care and long-term care. Robert also coordinates the activities of the Alabama Public Health Practice-Based Research Network. So with that, I'd like to turn it over to you, Summer and Rob.
Yes, hi everyone. This is Rob Weech-Maldonado, and Summer and I are very excited to be able to present you our findings, some of our findings from our study, and thanks so much for joining us. We would like to also acknowledge our other investigators at both the Alabama and California teams, and as well as the different organizations. In addition to University of Alabama, we have University of California, Berkeley, the Public Health Institute, University of California, Merced, and the Public Health Practice-Based Research Networks of both California and Alabama. And I'm going to provide a quick overview of our project aims. In the first aim, we're looking primarily at the scope of STD services as well as the organizational partnerships involved in providing those services. And then in the second aim, we're going to focus on disparities and particularly in terms of gonorrhea. Just to give you a quick background, for the reasons of focusing on gonorrhea for disparities, there are definitely serious implications in terms of untreated gonorrhea infections. We also, in terms of looking at different STDs, gonorrhea is one that has the most reliable data and is least affected by comorbidity screening issues. And third, there are very large disparities in rates in terms of gonorrhea in both Alabama and California. So just to show you some quick figures, in the first figure, as you can see, in terms, this is just plotting the rates for the different racial ethnic groups for both states, and as you can see, definitely disparities, particularly between black and whites. In the next slide, it kind of breaks it down by state, and Alabama has larger disparities, black-white, larger disparities, but as you can see also in California, there are black-white disparities, and they have been, the rates among blacks have been growing, although for other groups, the rates have been also going up. So when we look at the actual ratios of the black, white, Hispanic, white rates in terms of gonorrhea, this figures kind of shows you the different trends in the disparities. Now in the next slide, I'm going to summarize some of the things that we found in terms of looking at these disparity ratios. And so basically when we look at them, we see that there was a decline in the black-white disparities until 2012, but then started rising again in California in 2013. But we also see that there were rising rates in both groups. When we look at also in California, but the Hispanic white disparities, they have remained relatively flat. However, the rates for both groups have been increasing during this period. Then when we turn into Alabama, we see also that black-white disparities declined slightly, but when we look more closely at the data, it was primarily because the rates in white have been going up. So, and there's still, huge disparities, about 11 times the rate in whites in Alabama. So in summary, we have seen some declines that are not necessarily uniform, but when we look at it more closely, it's not necessarily improvements in health. Oftentimes it's just that the rates for whites have been going up. So in this presentation, or this part of the presentation, we want to look at what are some of the factors that may be driving some of those disparities in terms of both the local health department, STD service organization, but as well as other community factors that we would consider risk factors, social demographic, socioeconomic, healthcare access at the county level. Summer.
Thanks so much, Rob, and great to be on the webinar today. Thanks for everyone for joining us. So in addition to some of the racial disparities that we were investigating with our two aims, we also, for this scope aim, we wanted to understand a little bit more about how the era of healthcare reform has shaped local health department service provision for STD services. So we are aware that, typically speaking, better resourced local health departments tend to have more service offerings. But we really we know little about what is being offered for smaller or lesser resourced counties across the nation. And we also sought to understand in this aim a little bit more about how organizational partners play a role with local health departments to be able to provide services. So these were our guiding questions leading into the scope aim. So as we move through our two aims, I want to highlight and drill down a little bit more around the specific characteristics of local health departments that we were hoping to both define and then analyze as part of this project. So I just talked a little bit about what we're calling scope, which is really sort of the who, what, where. It's what services are specifically being offered, or what are LHDs, quote, doing, and with whom to provide services at the local level. Differentiation, integration, and concentration are three other ways of understanding and describing local health departments that we were interested in classifying departments by those categories. So differentiation really it refers to the differences, or how narrowly or broadly evidence-based services are being implemented at the local level. Integration refers to the extent to which local health departments are relying on partner organizations in order to execute and offer those services. And finally, concentration is the understanding of the extent to which the local health department itself is responsible for offering that service provision, as opposed to their partner, primarily their partners. So our colleague Hector Rodriguez, who is a project lead with us here in California, has developed through the data that we've collected in a process of taxonomy of how we can characterize organizational partnerships and characterize local health departments. So our goal here was to score or create a taxonomy of health departments based on high, medium, and low differentiation, integration, and concentration. So Rob is going to speak a little bit later on about how we use this DIC measure in order to test differences and disparities. So I want to give you an overview of our methods briefly. So we had 3 data sources for both of these aims on scope and disparities. Our first data source was a web-based local health department survey, which went out to all health officers and STD program officials in California and Alabama in 2015 for reporting on the prior year, 2014. This survey was specifically targeting what specific services were offered, who was being partnered with in the county to offer these services, and then also a little bit about the clinic level information in terms of funding and billing. For this data source, we sampled 76 and 62 jurisdictions in Alabama and California, and we were very fortunate to have a very high response rate overall of 91%, which resulted in a final analytic sample of 115 jurisdictions between the 2 states. In addition, we drew on data sources from the Public Health Department data on gonorrhea rates for Alabama and California, and also the Area Health Resource File for county characteristic data. I want to give you just I won't get into too many specifics on this slide, but we just wanted to demonstrate that for our quantitative aims, which include scope and disparities, we tried very hard to have not only an equal representation from California and Alabama counties, we also wanted to have a good spread or a good representation from counties of different sizes. So here, this slide is just to illustrate that we were very fortunate to have good representation from both large counties, medium, small, and very small counties to assess for size differences as well as differences in service offerings between the 2 states. I'm going to turn it over to Rob now to discuss a little bit about our analysis.
Yes, thanks, Summer. And so as a refresher, we have these 2 different aims. And for the first aim, we are interested in looking at primarily the availability of STD services and looking at whether there are differences by state and also by county size. So we ran some t-test, chi-square, and also regression analysis, and Summer will be presenting some of those results. Then for the disparities, we look at the relationship between the disparity rate ratios for black and whites, and looking then at the relationship with the LHD STD Service Organization and community factors, and we also included some state and year fixed effects. And just quickly here looking at for the disparities analysis in terms of the dependent variables, so we were looking at the black-white disparity rate in terms of looking at the case rates for blacks over the case rates for whites, and we did a similar calculation for the Hispanic white disparities. So in terms of what factors we were looking as far as predictors or correlates of the disparities, as Summer explained, we had this taxonomy that Hector Rodriguez had been leading that analysis. And in terms of the 3 different measures that go into the taxonomy, more just talking to you now a little bit about how we operationalize each of these measures. For differentiation, we did a count of 16 STD services, a lot of them what would be considered best practices. We then also, for integration, did a count of 27 possible organizational partners, such as schools, universities, community health centers, etc. Then for the concentration, we were interested in knowing to what extent the LHD was responsible for either all of the effort or, at the other extreme, none of the efforts because they were those services were provided primarily by community organizations. So then based on the scores that each county had for each of these dimensions, we classify each county into low DIC, medium DIC, and high DIC. And again, that would have been looking at these three components simultaneously. And as far as other variables, like I mentioned at the beginning, we were interested also in other community risk factors, so things that you would expect to be potentially associated with STD rates, population size, percent age 15 to 24, male-female ratio, the percent of black and whites, percent unemployed, percent population with high school or more education, percent of persons living in poverty, rural, urban, on the healthcare axis, percent uninsured, the availability of FQACs, and also primary care physicians per 1,000 population. All right, Summer with the scope of services.
Great. Thank you so much, Rob. So we're going to now kind of talk, Rob and I are going to toggle between both of our aims, results and discussion. And we just want to remind everyone, if you have questions, please put them in the chat box. We look forward to those. So as we look at what was available in local health departments in both California and Alabama, by and large, what we found is that treatment and follow-up services are not only universally available in both California and Alabama, but have very little differences in terms of their availability according to size of county. So treatment and follow-up activities for STD control and care were represented in 100% of all counties surveyed. Contract tracing, partner notification, and or referrals for STD treatments were also quite high for all STDs other than HIV at 96%. Investigations and referrals, 89%, and also partner notification. Many counties were also offering expedited partner therapy. So we're going to get into discussing this a little bit, but we found this to be one of our most promising first results. Prevention activities, screening activities were reported less so in our results. We also found, as a sort of what people are offering in terms of clinic offerings, we saw a trend for clinic closures, which was not so surprising, given that we were surveying people about the years preceding 2014. So 32% of LHDs that we surveyed had operating standalone STD clinics. However, 19 had closed clinics in the previous 10 years, while 4 in 2 states had opened new clinics. Prevention education activities at the local level was one of our least reported types of STD services, but we did find that condom distribution was the most prevalent or the most widely reported prevention activity at 80%. So I'd like to discuss a little bit here about the differences that we saw between California and Alabama. So here is a list of, we surveyed for 16 total services, and this slide shows the differences, statistically significant differences between California and Alabama according to service availability. So expedited partner therapy was offered in Alabama significantly more often in Alabama counties than in California. The remainder of the services listed here, California was offering these services more. So we see that even though condom distribution was very commonly reported, it was significantly more available in California, as well as rapid screening, preventive education activities, lab acceptance of rectal throat specimens, provider training, needs assessments, mobile screening, applications for prevention, and at-home screening services. So a lot of these types of services that we saw more prevalent in California fall into this prevention or innovative preventive service category. I'm going to talk about that on the next slide. So one of the more surprising findings from this survey and this analysis was that only 36% of the local health departments in both states that we surveyed reported that they do regular or routine targeted screening programs for at-risk populations, with 63% reporting in California and 10% in Alabama. The most common recommended populations noted where screenings were offered on a routine or ongoing basis were individuals in jails, sexually active young women, and men who have sex with men. So larger LHDs, which we have broken out into large and medium-sized categories for the analysis, did provide a statistically significant greater number of services, which is not a surprise. We knew that kind of going in. However, we did not see a difference, a reportable difference between small and very small counties, which indicated to us that there may be a threshold for county size when it comes to what services are available. We saw statistically significant differences in service availability according to size for innovative prevention practices and routine screenings for at-risk populations. So the larger the county, the more likely they were to offer innovative preventive activities and do more reliable routine screenings. Lastly, for scope, for our scope aim, we wanted to highlight some of the results and findings we saw about partnerships and our partnership activities and reporting. So we saw 4 organizational partnerships that were working with local health departments in both states to provide and offer STD services, family planning programs, private physician practices, advocacy groups, and hospitals and healthcare systems. These were all, as you can see by the numbers indicated, fairly well represented in terms of partnering with local health departments to offer a range of services. Alabama counties reported partnering more often with correctional health care and HIV clinics, and California offered or more often partnered with college and university health and wellness centers, and much more often with community health centers. And now I'll ask Rob to go through some of our results for black and white disparities.
Yes, thanks, Summer. Some of the major findings for the disparities was in terms of factors associated with the higher black-white disparities in both states. We found that counties with higher poverty, counties that had a higher proportion of blacks, and micropolitan areas compared to small towns, those were associated with higher black-white disparities. Now, in terms of lower black-white disparities, we did find that greater access to FQACs in the county was associated with lower disparities. However, the STD Service Organization, which was, as you remember, the differentiation, integration, concentration taxonomy, that was not significantly associated with black-white disparities. In this table, pretty much what I just described in terms of summarizing the major significant factors associated with black-white disparities. Now, turning into Hispanic-white disparities, in terms of factors associated with higher disparities, we found actually that counties with low DIC of STD services compared to high DIC were associated with higher disparities, higher county unemployment, and a higher proportion of Hispanics in the county were associated with higher disparities. We did not find any factor that was associated with lower disparities. And this is, again, the table kind of summarizing the significant findings for the Hispanic-white disparities. So now we're going to turn into some discussion and conclusion section. Summer?
Thanks, Rob. So one of our overarching questions with the scope aim was really to understand, given that we need to understand what types of services are being offered at the local level to be able to assess how that might change under health reform. One of the first guiding questions for us was, is the range or the scope of STD services available at the local level as we expected? And I think our main conclusion here is a complex one. It is kind of yes and no. We did, on the one hand, find that treatment and follow-up services have very wide availability, which is very promising, particularly for vulnerable populations. But we also saw that some of the more innovative, newer, or prevention-focused activities were really offered more on kind of a case-by-case basis, not necessarily based on resource or size, but sometimes even just political will or responding to needs in a community that may be distinct from other counties that are even of that same size. So a lot of variation in the types of services that we saw offered. So a little bit of some surprising things there. Our second kind of question and what has been guiding the scope aim was, how have local health departments adapted to national health care reform? So one of the things that we were not necessarily surprised to see is that larger, more resourced local health departments do appear to be continuing to be better equipped to offer a wider range of services. So for all of the new patients that counties have been seeing since ACA has been implemented in 2006, the more resourced counties appear to have remained a little bit more stable in terms of being able to take on more patients and meet that increased patient demand. But we also see that some of our smaller LHD departmental profiles do suggest that they're actually doing more with less, if that makes sense. They are actually shifting some of their service models and integrating care with other settings to be able to maximize the partnerships that they have to offer a range of services. So this is something that I think is notable from our analysis to really understand how some of the more rural or some of the more smaller and lesser resourced departments are adapting. One note here, and I think this is a big conclusion and big discussion point, is that if the ACA is repealed and replaced, we may be looking at a loss of clinical services. And so that adaptability, that agility piece that we saw with some of the smaller local health departments in respect to what services they were offering is going to be a point of really important future research.
All right, thank you, Summer. So we'll move now into the discussion about the disparities findings. One of the things that we were interested at the beginning was, does the STD service organization matter in terms of disparities? We found that at least for Hispanics, it seems to matter. Were counties that had low differentiation, integration, and concentration of services did have higher disparities than those that had high for both of those three dimensions. So this seems to imply that, when you have, greater provision of services, partnerships, and a larger control by the LHD in terms of STD services, that it does seem to help in terms of Hispanic-wide disparities. On the other hand, in terms of Black-whites, access to care seems to be more important. And like Summer was mentioning, in terms of the ACA, we know the ACA has provided additional funding for FQACs, so any potential rollback of ACA may have also implications in terms of access to FQACs. We also found that there are social determinants that can drive these disparities, particularly poverty, unemployment, and having more segregated communities. So policies that may improve economic opportunities in general, we think, of course, would that are targeted to minority communities can also reduce these disparities. Now, study limitations, we cannot imply causality, only association. And also, we are not able to really assess directly the effect of ACA on Medicaid expansion on disparities, since our data goes to 2014, and a lot of the effects of ACA and Medicaid expansion were after 2015. As far as next steps, we are working diligently in terms of our publications. Some of them are currently being reviewed. And also, we would welcome any potential collaboration we may have, for example, of looking at this taxonomy in other states and other jurisdictions and see whether we can replicate these findings in other communities. And like Summer mentioned, as far as ACA and potential implications that may have in terms of STD services and disparities.
Well, thank you, Rob. Thank you, Summer. And we just want to remind everyone that if you have any questions for our presenters, you can type them in the chat box at the lower left-hand corner of your screen. So before we go to our commentators today, I'd like to first introduce them. We have two of them, beginning with Dr. Lori Bilello, who is a research assistant professor and associate director for the Center for Health Equity and Quality Research at the University of Florida College of Medicine, Jacksonville, where she conducts and oversees applied research on clinical care and health disparities with a focus on the public health and healthcare delivery systems. Lori has also been integral to the work of the Florida Public Health Research Network. Our other commentator is Do-Reynoso, who is a public health director in Madera County, California, and a PhD candidate at the University of California, Merced. Vaughn has been a leader for Madera County Public Health as well as for county behavioral health and human services programs for more than 10 years. Vaughn also leads the 8-county San Joaquin Valley Health Consortium, which engages public health leaders in strategic planning, training, policy development, and research to improve the quality and responsiveness to public health issues. So with that, I'd like to turn it over first to you, Lori, for your comments.
Great. Thank you, CB. Well, I found one of the most interesting aspects of this research for me was the taxonomy of STD services. With similar studies we've done in STD services, there was a great deal of variability of the types of services local health departments provided, the depth of these services, as well as the types of partnerships with community-based providers that may impact their scope of services. This is especially helpful when you're comparing public health services between two very different states, such as California and Alabama, or across counties of different population size. By having a clear taxonomy on key factors such as differentiation of services, integration of community providers, and concentration of effort for STD control really helps neutralize some of these variations. However, I just I want to add a word of caution regarding the intensity of certain types of STD services that are performed. For instance, a local health department may say they're doing partner notification, but to what extent? Are they doing it for all their positives or just MSMs or some other subset of their population? Oftentimes, you really have to drill down deeper to be able to compare services across jurisdictions. Another finding that I found really interesting is the association of greater access to federally qualified health centers and lower disparities in gonorrhea. Generally, FQHCs have not been known to do a lot of STD screening and treatment, but with the increased partnerships that California has forged with these centers to do STD screening, FQHCs have become an important asset in STD control. There has been a substantial increase in funding for FQHCs over the last few years at a time when many health departments have seen a decrease in public funding. There's more funding expected for FQHCs in the proposed replacement of the ACA, the new act or proposed act known as the American Health Care Act. Public health really needs to continue building relationships with FQHCs since they can play an increasingly important role in STD screening and treatment. Furthermore, as FQHCs become more and more important in providing these public health services in general, researchers such as us focus on public health services and systems will need to investigate how these expanding roles impact population health. One other note I wanted to add is looking at the California rise in STD rates, especially in the minority populations. One of the factors that may influence that is their strong testing and outreach programs. So the more you test, the more you're going to find. Even for gonorrhea, which generally there is symptoms, but oftentimes can be asymptomatic or not enough symptoms for people to want to come in and get tested. So that may be one of the reasons why we saw the increased rates for California. And lastly, I just want to thank you for the opportunity to provide this commentary on this very interesting and important research that was just presented by Dr. Weech-Maldonado and Dr. Starling. Thank you so much.
Thank you, Lori. And I'd like to turn it over to you, Vaughn, for your comments.
Great. Thank you, CB. Thank you, Summer and Rob, for this incredibly meaningful and insightful work for us practitioners. So as a representative of the San Joaquin Valley Public Health Consortium, which again is 8 counties in the heart of California. So the backstory is that collectively we've been labeled as the Appalachia of the West. Largely because of the dire socioeconomic and health conditions that exist across our region. It's well known that we also lead the state in having some of the highest STD rates. So last year, the public health directors as well as health officers formed an STD work group specifically to look at how we can improve services to our at-risk populations, not necessarily through increasing services, but looking at systems, policies, and the environment in which we're operating in order to reduce the STD rates across our region. So this work is valuable to us because for 2 things. One, it points to partnership and the necessity of partnership in order to decrease STD services. We're accepting the reality that funding to local public health departments for STD services will not be significantly increasing in the near future. So the findings from this work will assist our regional STD work group in looking at how we can improve linkages with healthcare providers and other external agencies to do the prevention work, to do the screening work, as well as to do the treatment services. I think public health departments as a group, we tend to focus on the communicable disease aspects of STDs. We're great at investigating and treating the affected members. But if we have to, in order to affect change, we have to look at engaging our FQHCs, our private providers, as well as other providers in the community. Collectively, our 8 counties have not done much in engaging providers in education. And so this is a valuable finding for us because it will help us to shift our limited resources, not necessarily in doing treatment services, but focusing it perhaps towards provider education. And then the second part that's valuable for us is that We really haven't looked at the racial disparities in STD infection rates. So this is something that we'll need to look at as a work group and include it in part of our scope of work. So in looking at the policies and looking at the systems and the prevention and treatment services, what's available, are they hitting the mark for at-risk communities? Are they culturally appropriate? And again, it's not just looking at that for us, but engaging our healthcare providers and other service providers in addressing those, looking at what we have in place and tweaking it to make sure that we can impact the rates in our Latino communities and in our Black communities. And so on behalf of the region, I thank you for this opportunity to make commentaries.
Thank you, Vaughn. Thank you, Lori. And before we turn it to the audience for any questions that they may have about the presentation, we'd like to give some time to Summer and Robert to respond to the comments that Lori and Vaughn provided. So Summer and Robert, I turn it back over to you.
Yes, thank you, CV. Summer, I'll get started and then I'll turn it over to you. But yeah, thanks so much, Lori and Vaughn. Great comments, and I certainly appreciate, Lori, when you mentioned, one of our measures, differentiation, pretty much a count of services. So looking really at, differentiating between, in terms of the depth in which they provide those services, will be something that we should explore in other iterations of this taxonomy. It also was reassuring to know that for the American Health Care Act, which is the new healthcare reform that is being presented, that they're recommending also additional funding for FQAC. So that's good. And Vaughn, in terms of your comments, I appreciate, that there is, that our study can also highlight the importance of looking at the disparities in STDs. And one aspect that we certainly did not look at because of data limitation is whether these services are culturally appropriate. So that's one aspect that will have to be looked into the future as well. Summer?
Yeah, thank you for your comments, Lori and Vaughn and Rob. This is a fascinating discussion. Lori, I wanted to thank you for your comment about taking some of this data with a grain of salt and really making sure that we're not necessarily overreaching in some of our descriptions of what health departments are doing. I want to offer just sort of a note here that we did encounter a lot of challenges in the field with our scope aim that was around common definitions of what offering something means. So I think, for example, when we got the finding back that we saw big differences in how California and Alabama were conducting screenings, one of our advisors in California, this really put a flag up for her, and she was saying that, how can this be? I mean, she's like, I know that this one county is reporting that they do screenings, but I don't think that they do. And so we had to dig a little bit deeper into the stories and the understanding behind the numbers. And just to say that there are a lot of field challenges for trying to assess STD service provision as it currently stands, because a lot of counties just operate them differently. And we also observed very high staff turnover, and in another part of our analysis and our findings, we observed that a lot of clinics have people working at just fractions of FTEs. They're trying to piece together the necessary personnel for all these different service provisions across, fractions and really small fractions in some places of FTEs. So all that just to say that there's a lot more room for thought here, and that our findings on what's available should be challenged and looked into, and definitely warrants further research.
Thank you, Summer. Thank you, Rob. And so we'll open it to questions from the audience. I would like to remind that if you may not have thought of a question for this webinar, you can always forward those questions through the center, or you can also contact our presenters directly. So I guess just to get it started, we do have a question from the center. I mean, do you have any suggestions on how health departments can start to build new partnerships, particularly in low-resourced communities?
Vaughn, not to put you on the spot, but since this is kind of, like you said, you actually serve communities like this, I was wondering what were your perspectives on this?
So I actually had this conversation yesterday with a colleague about your presentation this morning, and what surprised me was, and he is a private provider, he said, I didn't know this. And so that brought home to me the fact that one of the things that what we can do as local public health departments is to take some of your data as well as other data that we have available in order to go out and build that partnership with our FQHC and our rural health centers and our private providers, and showing and demonstrating that these are the stats facing our community. And so we'd like to engage you in how do we resolve this issue? How do we decrease our STD rates, particularly in these at-risk communities? You get funded to do this. We get funded to do this. And so having those initial conversations, but starting with data, it was surprising to me that that he was not aware of the trends and the that's facing our community. So that would be my suggestion.
Yeah, no, that's great, Vaughn. One thought I had in terms of this area, particularly if it's an area that is served by not-for-profit hospitals. Right now they have these hospitals have the challenge that they have to develop these community health plans, but also an implementation plan. So making sure that the health departments are engaged with hospitals, because hospitals, not only in terms of community health plans, but a lot of them are also trying to join accountable care organizations, so looking more at population health. I think will provide an opportunity for local health departments to be better integrated. This, of course, may be more relevant in more urban communities, but it would be one way to continue that engagement in terms of public health issues, but that now the healthcare system is realizing that it is important for them to address those issues as well.
So we have a question from Jennifer. Do you have any advice for health departments in terms of engaging with, I guess this is correctional healthcare sector in STD prevention, or correctional facilities in STD prevention? So this question also goes out not just to presenters, but also to everyone, our commentators too as well.
I can offer an observation that I hope maybe someone can jump in and supplement here too. So we found that a lot of local health departments were already working with correctional facilities for STD screening and prevention. And what we had heard, because we had a whole other part of this, our analysis that focused on qualitative interviews with local health departments, that a lot of their venue or sort of their foray into working in the correctional system for STD care came about through correctional screenings for HIV. So we heard from several departments that they were able to build on the existing infrastructure and partnership with corrections around HIV screening, which in many states is mandated for incoming people coming into the correctional system. So they were able to build on that, and I think we heard a couple of places too where that was quite a beneficial partnership for expanding the scope of STD screening.
And that's right on. That's been our experience too. The other observation that I would make also is that our county was able to engage our corrections by separating our vital stats, and we were able to take the stats of infection rates from the general population as opposed to what's happening in the jail and the corrections. And that's how we initiated our conversation, I want to say about 3 years ago, and offer suggestions, offer support. And so corrections is one of our more effective partnership that we have.
Excellent. If there's no more question, I guess we could end it in terms of, you were speaking, Summer and Robert, about sort of, these funding environments given potential changes to the healthcare policy environment. You did talk about, how the differences in these STD control services, the scope and organization between California and Alabama, and probably between also the different states. Could that also be a function of the differences in the cost of providing these services? Would you have any information or insight into that? And is that something that, could be looked into in the future, given, as we always talk about funding, we also have to talk about the cost of providing these services too as well?
I can take the first stab on that question. I think absolutely it does. And I want to highlight that another limitation, particularly for the scope, aim, and paper, we didn't control very much for how specific services were funded, in contrast to other more core services that the county may offer. We kind of kept our billing and financial survey questions more at the clinic level. I would absolutely say yes, that part of service offering is definitely going to be about where the local health department is located and what kind of funding that they have. And I almost think that very much in tandem with the funding issue is also a regional or a location issue. So one of the reasons why California and Alabama make a good consortium and a good two-state comparison here is that we actually do have, like Vaughn was mentioning, we have counties in both states that are very rural in both states, and that have where the people who live there have very limited, some limited options for where to receive STD care beyond just the local health department. So I think that there's a regional and a sort of a rurality issue here, as well as a funding issue, which I think they both feed into each other.
Any final and additional comments, Robert?
No, I was just curious, since Lori is in another state, Florida. So I was wondering if, in terms of your perspectives from Florida, how does this resonate with you, Lori?
Great question.
Right. I think, basically we had so much variation across our counties, and we have some very small counties and very large counties. And when we were doing our study, it was really hard to put a finger on what they're doing and how you can compare what they're doing from one county to the next. And I think the DIC taxonomy is going to help somewhat for us as well. But I really think the biggest issue we have here is the whole overall funding decrease of public health services in general and STD in particular. And not just from the recession, but just the whole public will or interest in public health has seemed to decline, and so the funding's been declining. So I think that's the next step in the research is, what's happening to public health and STD control because of the decline in funding, and maybe the shift to the private sector such as FQHCs and other providers.
Yes, thank you.
Well, excellent. So again, we'd like to thank you, Robert and Summer, for your wonderful presentation and the excellent work you've done with your research. And we'd also like to thank, again, our commentators, Lori and Vaughn, for your time as well and in sharing your insights and commentaries. So we'd like to remind everyone that today's presentation is available for download along with our past webinars too as well. And so we invite you to visit the Systems for Action website to take a look at those webinars. And we'd also like to invite you to an upcoming webinar on understanding the rural-urban differences in the implementation of population health activities, which will be held next week. So with that, I'd like to thank you again, Robert and Summer, for your presentation, and also to our commentators, Lori and Vaughn. And thank you everyone also for joining us in today's webinar. We look forward to seeing you again. Have a great day. Thank you.